Hello and welcome to Perspectives on PH. I'm Thomas Baldrick. PAH.TV brings you up-to-date coverage on some of the latest abstracts presented at the 2013 American Thoracic Society International Conference. For all the related abstracts presented in PH, please visit the ATS website. We're pleased now to welcome Dr. Sean Studer, Clinical Associate Professor, Drexel University. Dr. Studer will highlight key abstracts presented during ATS that are especially relevant to patients with PAH. Welcome, Dr. Studer.
Thank you, Tom. It's very exciting to be part of this discussion because the American Thoracic Society this year in 2013 really highlighted a lot of the developing research in both treatment and other aspects of patient care for patients with pulmonary arterial hypertension. The first abstract I wanted to discuss with you was an oral presentation entitled The Addition of Variprost to Existing Sildenafil Therapy in Patients with Pulmonary Arterial Hypertension. This was a randomized open-label trial completed in Shanghai, China, which was termed the BEST study. This was a randomized controlled trial of Variprost or no Variprost in patients receiving stable sildenafil 20 milligrams 3 times daily for approximately 3 to 6 months as monotherapy. It examined the change in baseline 6-minute walk distance, World Health Organization or WHO functional class, and N-terminal pro-brain natriuretic peptide or NT-proBNP, which were assessed at weeks 12 and 24 in the study. These changes from baseline in hemodynamic parameters were assessed at week 24, and there were 60 total patients that were examined in this study. The panel on the left side in this next slide shows the 6-minute walk distance, which for monotherapy patients was significantly less than that which was achieved in combination patients. There was only 5.6 meter improvement in the sildenafil alone group, while there was a 50.8 meter improvement in 6-minute walk distance for the combination therapy group, giving us a control-adjusted difference of 45 meters approximately, with a significant p-value of 0.04. Other significant endpoints in this study included World Health Organization functional class improvement, which was 33% in combination versus 6.7% of those in monotherapy, again with significant p-value of 0.01. And at 18 months, 20% and 43% of the combination and monotherapy patients respectively had a clinical worsening event. So it appears that the combination reduced the chance of clinical worsening, again at a significance level of p of 0.027.
Dr. Studer, what is your impression of the information presented on Variprost in the BEST study?
Well, we were excited about the results of this study, Tom, because part of the background and significance of this study presented by Dr. Jing and his colleagues is that, as most PAH clinicians know, there are currently no oral prostacyclins approved outside of use, except in Japan, where Variprost is currently approved. There have been previous trials at 3 months that suggested Variprost was a significant improving factor in 6-minute walk distance. However, a subsequent trial that looked at 12 months, a randomized controlled trial in the United States, failed to show any sustained benefit. And for this reason, the FDA did not approve oral prostacyclin therapy. Seeing therapy like this from Jing and colleagues encourages us, that is clinicians caring for patients with PAH, as well as the patients themselves, and makes us optimistic about the potential future for other oral medications acting through the prostacyclin pathway, as well as perhaps Variprost itself. And the next presentation I'd like to discuss with you from the American Thoracic Society was entitled Combination Therapy with Spironolactone and Ambrisentan for the Treatment of Pulmonary Arterial Hypertension. It was a retrospective analysis of the Aries 1 and Aries 2 trial data. Now, some of the background for this trial is that there's data from both basic and translational models of pulmonary arterial hypertension that suggests hyperaldosteronism can modulate an increase in pulmonary vascular disease, and therefore there's great interest in easily available medications such as spironolactone for the potential treatment of this aspect of pulmonary arterial hypertension. In the trial, the investigators examined clinical data from patients who were randomized to placebo or ambrisentan at the 10 milligrams per day dose, in whom spironolactone use was reported as part of their routine care during the Aries studies 1 and Aries 2. There were 132 patients in the placebo group, 21 of whom were using spironolactone, the remaining who were not on spironolactone and only placebo. And there were 67 patients in the ambrisentan group, 10 of whom were on concurrent spironolactone. So as we see on this next slide here, looking at the results from the study, on the left we have figure 1 from the abstract, which shows a change in the 6-minute walk distance from week 0 to week 12 of the study. There are 4 curves represented, showing the placebo in black at the bottom, spironolactone in red, blue, which is ambrisentan, and then at the top, the green curve, which is spironolactone plus ambrisentan. What this curve demonstrates is that the spironolactone plus ambrisentan combination caused patients to achieve a 74.2-meter improvement in their 6-minute walk distance over the 12 weeks of the trial. And this compared favorably to the 38.2-meter improvement of those who were on ambrisentan without spironolactone in the blue curve just below it, with a 38.2-meter improvement. Now, the p-value we see here is only 0.1. However, this is a post hoc analysis, which is generally considered more for hypothesis generation than for something we would take as primary data from a study. Now, turning our attention to the curve on the right, or the figure on the right, I should say, which is the bar graph there, this was a comparison of predetermined clinical events in patients on different treatments. And we can see here there's the placebo group on the left, followed by the spironolactone, and then the real 2 comparison groups of interest was with ambrisentan plus spironolactone and ambrisentan without spironolactone. And what we see is that there is no real bar graph or bar demonstration, because 0 out of 10 of those on spironolactone plus ambrisentan experienced a clinical worsening event. That is, none of the patients did, compared to 3 out of 57 patients on ambrisentan without spironolactone.
So, Dr. Studer, how do you advise physicians to use the information from this retrospective analysis of the Aries study? Should they start prescribing spironolactone to their PAH patients?
I think it would be a bit premature, Tom, to suggest that clinicians go out and begin prescribing spironolactone if they wouldn't otherwise use it as part of the patient's routine care. This data is very intriguing and interesting, and I think it deserves further follow-up. And as the authors readily acknowledged in their conclusion, we really need sufficiently powered, that is, having enough patients in a prospective clinical trial in the future to characterize this observation and determine if it's something we can translate into a routine clinical recommendation. So this third abstract I'd like to discuss was entitled Unique Predictors of Mortality in Patients with Pulmonary Arterial Hypertension Associated with Systemic Sclerosis in the REVEAL Registry. And some of the background for this study is that we know that patients with pulmonary arterial hypertension associated with systemic sclerosis tend to experience higher mortality rates than patients with idiopathic disease, as well as those with other connective tissue disease that are associated with pulmonary arterial hypertension. And the authors really sought to look for predictors of mortality in this systemic sclerosis-associated population. So perhaps we might identify additional therapies or targeted approaches that could help reduce this mortality risk that we know those patients experience. Their analysis identified unique predictors associated with systemic sclerosis in connective tissue disease-associated pulmonary arterial hypertension, or CTD-APAH. They developed Kaplan-Meier curves to estimate all-cause mortality from time of enrollment in both the newly and previously diagnosed population, and then in their analysis did a log rank test to assess differences between the groups. They also used Cox regression models to identify significant predictors of mortality in the systemic sclerosis-associated PAH population, which totaled 504 in the registry, as well as in the non-systemic sclerosis connective tissue disease-associated population, from which they had 305 patients in that population. When we look at the data in the curves on this next slide, what we can see is a survival curve in the left panel representing the survival differences for newly diagnosed systemic sclerosis APAH patients with newly diagnosed non-systemic sclerosis but still having connective tissue disease APAH patients. And we see there that there was a demonstrable difference. The survival was 52% approximately in the newly diagnosed systemic sclerosis, while it was 76.5% at 3 years in those who had non-systemic sclerosis CTD-PH. Now, if we turn our attention to the Cox regression model predictors, which were found on the right side of the panel, these were those that were significant, and several were selected from a large chart that was included in the abstract. It was noted that age greater than 60 increased the hazard ratio. You can see it there at 1.36. New York Heart Association functional class 3 or 4 increased the hazard rate for mortality at 1.32 and 3.4 respectively. Having a low systolic blood pressure at the time of study entry, defined at less than 110 millimeters of mercury, increased the hazard to 1.65. Having a low 6-minute walk distance, that is less than 165 meters, increased the hazard ratio to just over 3 for mortality. Having a pericardial effusion, a known high-risk factor in general in PAH, increased the hazard risk to 1.35. And patients who had a low diffusing capacity, predicted at less than 32%, had a hazard ratio of 1.58.
What was your most important takeaway point regarding patients with connective tissue disease and PAH from the REVEAL registry data?
Well, I think the most important takeaway from this study is that we've often considered patients with connective tissue disease to sort of globally have a higher risk of mortality than those who had non-connective tissue disease and in some other form of PAH. What this study demonstrated is that specifically systemic sclerosis-associated PAH has a higher mortality than non-systemic sclerosis, yet still having connective tissue disease PAH, including illnesses such as perhaps overlap syndrome and lupus. And I think further it showed us that we can actually identify predictors in the systemic sclerosis population that up front may alert us to the fact that they have this higher mortality and may push us to try other treatment approaches, other therapies, or perhaps future investigations in this population to help bring up their survival rate and blunt some of that increased mortality effect that we've observed.
Thank you, Dr. Studer, for this insightful analysis. That's Dr. Sean Studer, Clinical Associate Professor, Drexel University. Thank you to all of the experts who contributed to this edition of Perspectives on PH. We look forward to seeing you here at PAH.TV as we cover the latest news in pulmonary hypertension.